Hello, everyone. What a great morning of conference we've already had. It's my pleasure to introduce the last of this morning's sessions, which is Access to Genetic Services, How to Level the Playing Field. So for this session, we'll hear again from Roseani Sanchez from Family Voices National, along with our second speaker, Charite Ricker. Charite is a clinical instructor of medicine at the University of Southern California and the director of genetic counseling at the LAC plus USC Medical Center. She's been a cancer genetic counselor for almost 20 years. As a Spanish genetic counselor of Cuban descent, she has been particularly focused on improving access to cancer genetics to the Hispanic and Latinx community. We're excited that she could join us today to share her expertise, as NIMAC is also working on several initiatives to increase access to genetic services for the Hispanic and Latinx community. So welcome, Charite and Roseani. You should be able to now share your screen, I believe. I think you're both.
And that looks good. We are seeing
me and see my screen, correct?
Yes. Check
okay.
To both.
Success. As I was sharing with Fred this morning when I came in to the office at 6 in the morning, my computer had completely crashed and I had to call in IT, but the plus of that was nobody else was using them at 6 in the morning. So I was a little worried that you would be able to see everything correctly. So I would like to first thank the meeting organizers for the opportunity to participate in this amazing conference, which I have gotten so much out of already, and am very excited for potential connections and collaborations, as I think many of us, no matter where we are in the country or the world, are facing many of the similar struggles for patients and families in accessing genetic services. So Roseani and I will be discussing today how to level the playing field with regards to accessing services. And just to begin with, neither of us have any conflicts of interest to disclose. And during our time together today, Roseani and I will be working towards addressing these objectives as listed here, which I am also excited to have seen woven into many of the previous presentations and discussed throughout the conference thus far. What I think is really interesting and notable is that the majority of the barriers and obstacles that have been discussed throughout the meeting are what we call social determinants of health. And so these are non-medical factors that influence an individual's ability that influence certain health outcomes. And these are things like the conditions in which people are born, in which they grow up, they work, they live, and they age, and also a wider set of forces and systems that shape the conditions of daily life. And as we think about, which I'll refer to as social determinants of health, or SDOHs, over the course of our conversation today, they can actually be defined in many different ways, and different domains are used to capture SDOHs. In some settings and organizations, or even professional fields, they might be classified as few as 3 SDOHs or as many as 12. But for the purposes of today's discussion, we'll consider the 5 domains that are utilized by the Center for Disease Control and are highlighted in the Healthy People Public Health Objectives for 2020 and also for 2030. And so down here at the bottom, you can link to those if you'd like a fuller conversation about what these domains are. But the 5 CDC SDOH domains are economic stability, education and access, education access and quality, healthcare access and quality, neighborhood and built environment, and the social and community context. Now, I think we could probably sit here for the remainder of our time and just talk about these social determinants of health and how they apply to genetics and accessing genetic services, which in many ways we have already been doing over the course of this meeting. And one of the exciting things I saw yesterday morning was Alyssa asked the group, what do you see as the biggest barriers in families accessing genetic services that they need. And this word cloud here was generated by y'all. And sorry, I should have put my pointer on. Where is it? Okay, that was not what I meant to do. I don't know how to undo that. So we're just gonna move this over here. Oh, there you go. Okay, sorry about that. So here you can see the word cloud that was developed yesterday by the participants in the conference. And your responses are captured in such a way that we immediately noticed that one of the greatest barriers was cited as being transportation. And if you look across all of the different barriers that are listed, you'll notice that almost every single one of them is a non-medical factor, not something that necessarily has to do with the individual's medical history or the family's medical state. As I'm sure we all know by now, after our year of almost exclusively Zoom interactions and doing fun things like word clouds, the size of the words and letters represent the frequency with which that particular barrier was cited. So as you review these responses from yesterday, what I thought we could do is maybe in the chat, first, let's answer this question. Do you agree that the barriers that facing patients and families to access genetic services are appropriately represented in this word cloud? Just yes or no. I know there's probably a lot of us in the question in the group that are more like maybe and perhaps or sometimes, but just straight yes and no. If you can submit your answers.
You're getting yes or no answers in the poll. So I'll show it to you in a sec.
Okay.
It's about half the people have voted so far. All right, if you're getting your last votes in, I'm going to close the poll. Conversations can continue in chat about this challenging yes or no poll in 3, 2, 1.
Thanks. Okay, great. So the majority of you feel like this appropriately represents the barriers faced by patients and families. One of the things that I thought that as we talk more about this topic, that might be kind of fun, and I thought about this early this morning, so pardon me if it doesn't sound as fun to y'all as it did to me as I was driving into work. I thought that perhaps we could look at this word cloud and in the chat match up the social determinant of health that fits with the particular barrier that was identified. So just as an example, we see one of the barriers listed is information not being family friendly. That would obviously fit well under the education access and quality domain. So I'll just give you all a few minutes to put your thoughts in the chat. And I am actually, I realize I am not seeing the chat. So oh, here it is. Okay. Let me move it over here. So great, we have some lots that fall under education access, insurance and healthcare access. Any other thoughts? Okay, policies and how they affect things like family-centered medical homes. That would probably fall under social and community context. Distance falls under the built neighborhood. Shortage of genetic counselors and geneticists fall under healthcare access. And so using social determinants of health resources, thank you so much, everybody. You can keep pouring these in. I feel like we're all taking a test where you have to draw lines between the matching terms and phrases. And I think that talking about social determinants of health just provides us a framework in which we can discuss these difficult barriers and factors that influence access to genetics and other health outcomes. So now I would like us to do the word cloud activity one more time, but this time I'm going to ask you a slightly different question. And the question is, from your perspective, what are the 3 social determinants of health that most influence access to genetic services? And I know that the team will put this Mentimeter into the chat so that you can access it that way. And as you do this, you don't necessarily need to use a domain per se, but just think about 3 non-medical factors that influence access. So we see a lot of the same themes emerging, although perhaps with different levels of frequency. Education is standing out a bit more now. Socioeconomic status. And I think what is also important to note is, depending on the healthcare setting that you work in or the patient population with which you work, some of these may be more significant. And thank you for putting your comments into the chat also. So I think maybe we'll just do this for for another minute or so, and then go ahead and move on. Okay, that's great. So we'll stop at a 42. Okay, are we just about there? So again, what we end up with is a word cloud that's very similar to the one yesterday, though with slightly different distribution of frequency of responses, with more of a standout for education. I'd like to highlight an article that was published earlier this year in Pediatric Research, which was titled "The Social Determinants of Health on the Genetic Diagnostic Odyssey: Who Remains Undiagnosed and to why and to what effect." And what I appreciated, so I adapted the figure that the authors had provided so that it was a little more readable on our Zoom screens. But we are
not seeing your slides.
Oh, sorry.
No problem.
So I'm not sure how I unshared. But
it's because when I shared the word cloud, I took over. Sorry about that.
Oh, gotcha. Let's go back. Okay, so here we are. So this is the article that I was just mentioning, the influence of social determinants of health on the genetic diagnostic odyssey. And what I appreciated about this article was their figure 1 is a process that we're all very familiar with. And that process starts with a genetic disorder or disease being suspected in an individual and ends with either a diagnosis being made or potentially diagnoses being ruled out. And in particular, this article was focused on racial and ethnic minority groups who we know face some of the largest disparities in access to genetic services. And their point made throughout the paper is that the social determinants of health, such as structural racism, patient-provider distress, life course trauma, history of eugenics, are prevalent across the course of the diagnostic odyssey for, in particular, racial and ethnic minority groups. And in addition, individuals may face barriers at every step. For example, providers may be less likely to suspect a genetic disorder in individuals from underrepresented minority groups. They may also be less likely to refer those individuals to genetic services. And then we meet with the additional structure, social or SDOH of differential access to care, which can affect the referral being completed. In addition, when somebody is seen by a genetics provider, a genetic syndrome may be less likely to be suspected, and tests may be less likely to be ordered for a variety of different reasons. And then we have to get to a test being ordered or a workup being done, and decreased access to health care may make the multiple appointments that are intrinsic often to our field difficult, and then sample collection complicated. And then lastly, as a diagnosis is being made, if genetic testing is one of the tools being applied, we know that there is an increased rate of uncertain variance in individuals of underrepresented groups, which leads to more difficulty in interpreting test results due to the lack of representation in reference samples. And so I appreciated this article and thought it was one that many of us could identify with and understand because it was in the context of a genetic diagnosis. I'm sure that this visual is probably an other that many of you have seen in some iteration over time. I know I've seen it represented in many different ways. And there's actually a really cool, I would point you to an article called The Evolution of an Accidental Meme to get the background on this particular graphic, its origin, and how this particular version came into being. But here the artist is illustrating the difference between equality, where all individuals are provided the same resources, which is what we see in this first box, compared to equity, where the resources provided are tailored to the needs of the individual. However, this particular version of this graphic or meme really was particularly impactful to me because I work in a clinic where I feel like my patients live in this reality box, where it's not just that there are unequal resources, but there are additional barriers, and the resources that exist are not distributed in any shape, form, or fashion equally. And so what I am hoping that we can focus on a bit as we move forward is, sorry, I'm having problems advancing my, okay, sorry. So my screen just crashed, my computer crashed. If you can give me a minute, I want to pull that back up again. My apologies. Oh, and thank you so much for posting that in the chat.
Charite, would you like me to share my screen?
Oh, do you have the version from this morning that I sent? It's opening back up now.
Okay.
I was going to say, I also have one that I can share, but I don't know when that one was sent.
Yeah, I think I'm here, guys. I apologize for that. Let me advance to the right slide. Okay, so I think we're back to where I was when my computer glitched, so we're good to go.
You'll just need to share your slides again, actually.
Oh,
So
great. I'm ready to watch my own presentation, but how about if I share that with y'all? Okay. Are we good?
yes, you're back.
Okay, okay, perfect. Thank you. Let me just move the chat over. Okay, great. Okay. So despite which of kind of these places we find our patients, either in an over-resourced setting or an under-resourced setting, I hope that our shared goal would be for justice for our patients, which we could consider being the removal of the barriers to service, which allows access to all. As we saw from both of the word clouds that were generated, the problems are complex and vary by clinic and population, so the solutions are likely to vary. However, as I would like to share a bit about how we approach the particular inequity to care that we faced in our genetics clinic. So I am in Los Angeles, which is a large and diverse metropolitan area that with more than 10 million inhabitants that cover more than 400 or 4,000 square miles. It is a racially and ethnically diverse city with the greatest or largest identifying ethnic population being individuals of Latinx and Hispanic background. What's also to me very rich and interesting is that we have a very large population of individuals who are not born in the United States. And it is actually more common to not speak only English in your home than it is to speak only English in your home. We have quite a few, like for example, when we think about our patients who identify or who are of Asian ancestry, that covers individuals of Chinese, Korean, Filipino, many different backgrounds. And we have several ancestral groups who have more people in LA than they do in their home countries, including Armenians and others. And so we, from a clinician's perspective, it is always learning about different groups and populations and what brings them to us in clinic and what brings them to our country. When I first started as a genetic counselor, my first position was at the City of Hope, but my second position was at USC Norris Comprehensive Cancer Center, which has been an NCI designated cancer center since the 70s, and like many cancer centers across the US is focused on cancer treatment, prevention, research, and education. In addition, so this is where USC Norris is located, the attendings, the oncologists, the surgeons at USC Norris are the attendings at LAC USC, which is just a block and a half away, which is one of the largest acute care hospitals in the US and the largest single provider of healthcare in LA County. And it was founded in the late 1800s and has been associated with the University of Southern California since 1885 as a major teaching and training facility. As part of the department, the LA County Department of Health Services Network, the patients who are served at LAC USC are un- and underinsured patients through a variety of no-cost or low-cost healthcare programs. When I started at Norris in 2004, there was no access to genetic testing, much less genetic counseling at LAC USC. However, the attendings recognized this need, and which was particularly pronounced because at that point in time, there was not only a lack of access to providers, there was also a lack of coverage for genetic testing by Medicaid. In 2008, we received the support of a grant, which along with the financial support of the Cancer Center, allowed me to go to LAC USC to establish cancer genetic services in collaboration with the Chief of Medical Oncology. And so as we were establishing the clinic, we thought we needed to think about what we knew about the patient population that would inform how our clinic was built. And if we look at the literature, it's important to note kind of the context of our clinic is that the majority of our patients, greater than 75%, are Hispanic Latinx, and most are either monolingual Spanish or Spanish preferring patients. Many are immigrants with relatively low health literacy and limited formal education. And the vast majority of our patients, regardless of their racial or ethnic identity, live below the federal poverty level and are under-resourced with extremely complicated competing demands in their lives. So the literature at that time reported that there was very low awareness of genetic testing for cancer susceptibility in Hispanics and other underrepresented minority groups. And though I cringe sometimes at the term underutilization, because I think it's difficult to measure utilization unless you are making something accessible, the literature reported that there were low rates of utilization of genetic testing in women of diverse racial and ethnic backgrounds. Prior to coming to USC Norris, I'd been at City of Hope, where we had done some research in collaboration with a different LA-based county hospital, and found that despite the limited understanding or awareness and access, there was high interest when individuals were made aware. And that was found across a variety of different research studies. Through that same project at City of Hope, we had established a clinic, an outreach clinic at this other hospital within the LA Department of Health Services network, which was All of You Medical Center. And what we found is that if we provided access to the cares at that facility, the patients came, they responded, and they attended their visits. And other clinics which were addressing similar needs within safety net hospitals showed similar results. So as we were establishing our clinic at LAC USC, how we set that clinic up was informed by my previous experience at All of You when I had been at City of Hope, and then also from other people's experiences that they'd reported on. So we identified certain facilitators to help better accommodate the needs of the patients and increase the ability to actually utilize and access our services. First, our services were provided within the population's healthcare system, rather than setting up a clinic that, even though it's only a block and a half away, rather than setting up a clinic at the Norris and bringing people over, we went to the county and established our clinic there. We utilized grant monies, commercial lab financial assistance program, and finally, after several years, worked with the institution itself to obtain coverage that met NCCN guidelines so that nobody was turned away regardless of their status. And in the interim, Medicaid California also came on board with guidelines for testing, which made a big difference. We provided point of care visits, which were integrated into medical oncology and gynecologic oncology, so that individuals could see the genetic counselor or myself in order at the same time as their other appointments. And especially at that point in time, many of our patients, when they came for their oncology visits, were here for most of the day. They were using public transportation, so they got here early. And the clinics are very busy, and so there was often a delay. So we utilized that time. And at the beginning, before I had support, I would almost ambush people, introduce myself, and if they were willing, we would do an appointment as they waited for their oncologist or schedule them for the next visit. And then we are able to provide language concordant genetic counseling for the 90% of our patients who speak English and/or Spanish. And currently it's myself and another genetic counselor, Daisy Hernandez, who see patients here. And my experience has been that the majority of patients accept cancer genetic testing when it's indicated and offered. And we've also run several research studies concurrently with our clinical care, and most are willing, interested, and even excited to participate in those studies. So I know that that's just a glimpse of of what I have found. And this approach has worked well within our facility, though, to be honest, we're experiencing huge growing pains as the demand for our services is greater than the clinical resources we have at hand. And so looking at some of the tools that have been discussed by other individuals to address those needs has become imperative. And as we have transitioned to telemedicine with the pandemic, we've had bumps and we've had issues that we're still sorting out even after a year. So I gave you the rosiest version of my experience, but I acknowledge that is not always as smooth as we would like it to be. As I finish, I wanted to share with the group another review article as a potential resource. And actually, I thought this merged really well with in particular, the talk this morning about integrating with PCPs. And this was a review article published earlier this year about the integration of medical genetics with primary care physicians, especially in the underserved population. And the authors identified that the three greatest barriers for PCPs to integrate with genetics was insufficient knowledge about genetics, the lack of access to services, and insufficient time to address these challenges. So the authors highlighted three strategies to overcome these barriers. And because we've actually spent quite a bit of time through other presentations on some of these, I won't go into too much detail, but just broadly speaking, one was telemedicine. And the only caveat I would say is that as we continue to use telemedicine more, it's important that we pay special attention to populations who are at risk for not being able to utilize those services, because it can serve to widen gaps that already exist. And so just using telemedicine with certain populations may require more adjustments and support than with other patient populations. The patient-centered medical home, which I think somebody had put in and I apologize, I should have been super skilled and gotten your name down, but somebody mentioned this earlier, how important the patient-centered medical home can be. And essentially this is partnerships between non-genetics providers, clinical genetics providers, and parents and families, which can be especially effective in enhancing genetic services. And the last, learning communities, which I was really excited to see. And oh, thank you, Dr. Ostrander. Yes, so was highlighted in the previous presentation this morning was Project ECHO, which provides a great example of a learning community. And these learning communities can provide enhanced training, evidence-based guidelines, and clinical tools that can more effectively support the delivery and facilitation of access to genetics and genomic medicine by primary care providers. So I'm excited to turn the time over now to Roseani, who will give us the patient and family perspective on this. And I'm going to, Roseani, I'm going to stop share so that you can start share. Okay.
Can you keep sharing so we don't have to switch over?
Do you want to just tell me?
I'll just let you know. Yeah.
Okay, perfect.
Okay, thank you, everyone. Well, welcome again. For the ones that wasn't in the session before, my name is Roseani Sanchez. I am from Puerto Rico, and I'm currently living in Puerto Rico. I'm a mom of twin boys with 6 years old with special healthcare needs. And I'm also a project coordinator at Family Voices National. So welcome all. I would like to share with you guys the family perspective accessing genetic services, the barriers that families need to overcome, and some life experience. And also, I would like to share some recommendations that can help families to overcome those barriers. Next slide. So here's my family. Having a child, well, in my case too, with special medical needs can change your life in an instant. There's many feelings that you face with a news like this. Some of them, like Coral was sharing with us in the session before, is fear, is guilt, is confusion, anger, and even shame. We don't know where to go. We don't know what to do. So you have many questions. Sometimes you don't have any answers. So it's a process. It's a process of accepting the diagnosis, healing those feelings, and educate yourself to be able to find the resources and the options that you have available. So it is a process. And for me, it was a little bit hard to understand and to accept that I need support from others and that I need some guide. And this is what really I would like to share with you all today. Next slide. Genetic disorder impact not only the physical health, but also the psychological and social well-being, not only for the patient, for the family and the entire family. Increasing the genetic risk or a genetic diagnosis can substantially impact the medical management, high levels of stress, and a big range of emotions. For this reason, it is very important that we count with different specialists, such as genetic counselors, social workers, psychologists, and even support groups that they can be extremely helpful for patients and families to deal with this difficult time. Next slide. Let's talk about some barriers that families are going through and face every day when they get a diagnosis like this. I would say that the main one is lack of information. We don't have much information available, and we don't have it either in our native language. So for me, it was very hard to find information that I could understand in Spanish. So I will say that that's one of the main barriers that families are facing right now. We don't know the differences between a provider, a geneticist versus another specialist. So knowing exactly what a specialist do and how they can help your child, I think that's very, very important. So knowing what kind of providers your child needs and what that especially can do for you is crucial. Insurance, especially in the genetic area, like Coral was expressing too. Here in Puerto Rico, we don't have insurance that cover geneticist services. They don't cover labs. They don't cover testing. So the coverage from insurance, that's another big barrier that families are facing right now. Next slide. Transportation, especially here in Puerto Rico. I mean, we're an island. We have a lot of families that lives in the rural areas, in the center of the island. We even have two small islands that they're called Culebras and Vieques, and they are separate from our island. So it's a challenge for families to get services when they're only in one area of the island, which is San Juan. So transportation is a big barrier for them. Not only how to get there, is the toll roads, the parking. Some of the parents have to take the whole day off from work because, I mean, it's so long, the distance, that they're not going to be able to work that day to be able to attend to the appointment. Labs and tests, that's another thing. I mean, I know that we don't have too many labs that they can do the genetic services and the genetic testing. So it is, I mean, the waiting time that families have to wait for the results, the cost. Many of the labs, they have to go to US to get the results. So it's a process where families are waiting, it's costly. And while that time that families are waiting for results, the stress level is very high. They're just waiting for the results, and it's a huge barrier for them. As well, the pharmacies. I mean, pharmacies available, prescriptions, medications. We don't have many pharmacies that they can provide the medications for this type of diagnoses. That's another barrier that families are facing. Next slide. So I know that since the session before, we see clearly all the barriers that families are facing. And I even give you a quick summary of the main ones. But let's talk a little bit more about how we can overcome those barriers. Next slide. Since the first one is lack of information, I think gathering information and become an expert, it will help parents in many areas. So for me, it's important for me as a mom and as a professional to empower parents and empower myself to get the information that I need. Educate ourselves and learn more about our child diagnosis. It will help us to go through that path more secure and more confident that this is what we have to do. This is how we can become partners with the specialist. This is how we can create a team that support our child and understanding what's going on with him. Overall, just having information, gathering information, and educating ourselves, it will decrease our stress level because we know what to expect. We know the path that we have to go. It helps to decrease our levels and also of stress, and also to make better decisions, to be sure that where we have to go. And in that decision making, you feel more confident. Focusing on understanding the unique aspects of genetic information, genetic testing, and diagnosis can help us to have a clear action to minimize the stress and maximize the benefit for them, for our children. So definitely gather information is something that I do myself, and I always empower other parents to do that. Next slide. Support system. I think this is my biggest one because a support system is the one that could help you to go through everything and all the barriers that you see in your way. Ongoing support. So in general, we can have support, advocacy group, community groups, family, providers that they can give you support when you are going through looking for what your child needs. It is important that the support groups that we choose provide us a forum to share experience, to know and learn about what works for others and what didn't work for others. Having a support system of other parents and other families that went through the same thing, it could help you to go and learn from their experience. Like, I mean, the experience that we learn and we listen in the session before, that's something that could help me to not to make the same mistakes. I think every experience is unique, but it could help you to make decisions quicker and to know exactly what works for others. Members of a support group can keep you updated to information. They can give you that hand that you need in a moment of crisis, in a moment that you don't know where to go. Where to find it, especially how I'm gonna pay for it, what resources I have available. Having a support system within the community, within your providers, and looking for the resources that we have where we live is one of the things that really can help us go through the process. Referrals, I think that's very important too. I mean, just having conversations with your providers. I really learned having two kids and go to the pediatrician with both of them. I have to take notes. I have to make a list of priorities and go through like one for each child because they're both different. So preparing yourself for that appointment before you actually see your provider, it's huge. It helps you. It helps you to clear your mind, to answer the questions and your concerns, and to create a relationship with your provider, which will help you to go through the process of who else needs to see my child, who else I need to be part of this team. So definitely preparing yourself for the appointments, it will make a big difference if you do so. Next slide. Lastly, I will say the financial responsibility. The financial concern of a chronic genetic condition can also lead us to a big stress with the family members and whoever support us. This is something that really touched me personally, having two boys. A family already struggled with many other things, and the financial responsibility, it could put us in a very difficult situation. And this is what, like, I think one of them, I think was Coral, who was sharing that it automatically put you in a question mark. Can I get these services? Can I get the services that my child needs if I don't have the money? And as a parent, I think that this is something that we have to advocate for, that medical services should be available for whoever needs it. And parents with child with special haircut needs shouldn't be in that position. Well, now I'm going to turn out to Charite. So she's going to finish with some of the other slide, and we will have a little bit time for questions at the end. Thank you all.
Thanks, Roseani. Again, I'd like to thank the organizers for pairing me with Roseani. It's been a pleasure to work with her, and I've learned so much from her just as we work together on this project. I wanted, and thank you for sharing your experiences and the perspective of families. I'd now like for us to reflect for a moment on another word cloud from Alyssa's presentation yesterday, where she had asked, what are some of the key solutions to the barriers that everybody had provided? And many of these we can see are directly applicable to a variety of clinical and practice settings, such as education, financial assistance, care coordination. What I would like us to do, however, is maybe think a little more specifically to your individual setting and situation. And earlier in the presentation, everybody had, or those of you who participated, had presented the 3 SDOHs that you felt were most impactful on access to care. And now what I would like you to do is to share your ideas about how you personally, in your part of the genetic space, whether you're a patient or a provider or an advocate, what you can do to level the playing field. And also, I'll direct you to this story-based change strategy for the 4th box, which has individuals kind of creatively generate their own images. And I'm not an artist, and I won't make you draw. I think that would be horrifying. But just if you can brainstorm your own ideas and solutions for how you would generate address this particular issue in your own clinical or personal setting. And Fred has put the Mentimeter in the chat, and we will see I'm not sure how many responses are rolling in, but if you want to go ahead and share your screen. So any other ideas? We have some universal healthcare would be nice. Outreach clinic. I love this one, ask about families' difficulties. So really speak to our patients and identify what is their particular need. Educational resources, collate resources. I think this is great a lot of times, and I think some of the efforts that NIMAC is doing to bring things together are really important. More telehealth out into the community. So know our communities and be a presence. And that helps with trust, with awareness, with making the genetic odyssey maybe not seem as much of an odyssey. Ignelli, thank you. Community outreach programs. Nothing for us without us. Thank you. I think that's incredibly important that the communities are involved in the development of our outreach efforts. Consider cultural and socioeconomic differences. Sorry, these are great. Listen to families, get more feedback, raise awareness, genetic tests covered by insurance, customize clinical outreach in the community, link genetics to family organizations. Navigators, I think these can be incredibly important partners in the process because often navigators are from the communities they serve and they're well integrated into existing resources and clinics. Did I miss anything in the chat? Let me see. I think we got everything. So how about we just take a couple more minutes to drop in any other ideas. Diversify the workforce, I'd missed that one. Pathway programs to increase representation also in the workforce. Raise awareness, partnering with PCPs. Genetics should be part of a physical exam that's covered by insurance. So I think these are a lot of amazing and great and exciting ways to create telehealth pods to increase access. These are really great ideas. And I think yesterday, one of the ones that had been highlighted was subway ads. LA doesn't have a great subway system, so I don't think that would be great for here. But for those cities where the subway is such an integral transportation, perhaps hub, that is, and it would be an exciting thing to explore. So I would just encourage everybody to think about your settings, the patients that you aren't seeing within your clinics who should be there based on what you know about the community you work in, and what can be targeted and directed outreach to increase access and to better meet the needs and mitigate some of the social determinants of health that are often leading to barriers. So I'm going to, do you want us to, let's go ahead. I think we've hit on most everything. Thank you everybody for sharing your ideas. And again, I would encourage you to continue these conversations within your particular work setting or support group or network that you're a part of. And that will allow, hopefully, some of these to become action and bridge the gaps that we often see in access. Every time I think about or contemplate this topic, I often think about a statement that I heard or read, actually, because it was in an article at the very beginning of my year of my career that left a lasting impression on me. And it was something that was said by Dr. Helen Meisner of the NCI in 2004, and she said, I hate to say cultural barriers. A culture is not a barrier. The barrier is that if we don't understand the culture, then we can't be effective in communicating what we think may be beneficial for health. What I would add to this, and I appreciated the nothing for us without us statement that was put into the chat, is that often we are focused on communicating what we think is beneficial for health without considering what our communities and populations are focused on. And so I would encourage us to not think about things like culture as a barrier, but our lack of understanding about it being the barrier, and what we can do to integrate what we would like to communicate with the needs and desires of the patient populations that we are trying to reach and to serve. And I think we're down to 5 minutes. So if there are any additional questions, and Roseani and I would love to address them or put them in the chat so we can have those conversations.
Well, people sharing any questions, thank you so much, Charite. It's been a pleasure to work with you and to do this presentation with you. Thank you so much, and NIMAC too, for the opportunity to include us in their sessions.
I'm looking at the chat and I'm not seeing any questions yet,
Yeah,
but
I don't see
it
any.
just takes a few minutes for people to enter them in.
So I would defer to somebody from NIMAC to comment on whether there's a next step. I don't want to speak for an organization that I'm luckily just now beginning to be aware of. And thank you for the resource, Alyssa, that you posted regarding diversifying the workforce. But I'll go ahead and mute. I don't know if, Andrea, if you want to speak to that.
Yes, so Alyssa listed in the chat for people to check out the Minority Genetics Provider Network, which has been a great resource. I know for many genetic counselors and other genetics providers, and also students interested in the field of genetic counseling, as well as the Golden program and the Dunn program, which are both programs that are being currently funded by NIMAC. And I don't know, Alyssa, Alyssa posted a link to the Twitter account for the Golden program and a link to the website for the Minority Genetics Provider Network.
Oh, sorry. So I think, and I'm just reading the chat and I see that it was, I guess, more a question of suggestions of what next steps could be. And what I have found incredibly fascinating about participating in the conference is that there's been a lot of efforts to identify in each of your respective region or areas of the region, I'm not sure how that's divided up, what those particular barriers might be, and a lot of great ideas that I've heard. I know what has worked well for us at our facility. I know some of the things we are looking at is because, as I mentioned, we have a higher demand than we're able to meet, is being able to move some of our patients to group sessions. Because Los Angeles is large, even though many of our patients have expressed a preference for in-person visits, we're going to keep a subset of our visits by telemedicine to accommodate the patients who are coming from very far away, which can be almost an hour or two by public transportation at times. We're looking at, we've trialed using a chatbot because it was available in Spanish and English to push out some educational material during the pandemic. And we are currently working on a research proposal that will use other forms of AI to provide some education. And so we're just trying to think very creatively about how we can leverage the resources we have. And so I just challenge everybody to look at your own situation, what your existing resources are and what your needs are, and identify ways to to try to match them up and then expand them. And I think that's often the challenge because there's not resources for everything that we would like to do or need to do. But it sounds like there's a lot of excellent efforts going on. And possible collaborations, which I think is exciting since you have such a dynamic and invested network.
Yes, thank you for that, Charite. And I'm seeing lots of thank yous and excellent presentations in the chat. And so I just wanted to echo that as well. Thank you, Roseani and Charite, for your talk, as well as all of the morning speakers. It's 12:15, so I am going to pass it back over to Erica.